Welcome to Bird Ultrasound Case of the Week. What makes you blush? I don't know about you, but I love it when someone blushes. It's the most human of characteristics. You can't control it. It means you have felt an emotion, your cheeks go rosy, and the whole world can see that you have had an emotional experience. And I just think that's wonderful. So, for all those people out there that blush uncontrollably, hats off to you all. I think it's just fabulous. But have you ever thought about what does make you blush? And I'm going to try and twist this around into a bit of a discussion about vascular hemodynamics and some of the things we see in our vascular arterial studies. We very commonly use this terminology where we describe a pulse Doppler waveform as being triphasic, and this is considered to be a normal type of waveform that we'd expect to see from a high resistance system such as a femoral artery would be a great example. In older patients, we very often see a biphasic waveform, and this is considered also to be entirely normal. And the difference between a biphasic and a triphasic waveform is simply a little bit of loss of elasticity of the vessel wall collagen, and this is considered to be just a normal part of the aging process. However, when we see a monophasic waveform, then in the leg artery example, this would always be considered pathological, and in this case we're seeing a delayed acceleration time and a lack of peripheral resistance, and we then give this the label of a monophasic waveform. I've never really thought that the description of triphasic, biphasic and monophasic is a way that I like to think about waveforms. A better way that I like to think about waveforms in terms of terminology is to consider the input pressure, the acceleration time, and then the peripheral resistance characteristics of that waveform, and whether or not we're seeing a Tardus parvus waveform, as was evidenced by that monophasic waveform on the previous slide. So from a practical perspective, I think what determines the shape of a waveform is the input pressure and the peripheral resistance. So let's have a look at a couple of waveforms. If you look at these two waveforms, this is the input pressure. So in other words, it's the time from the end of diastole to the peak of systole. So if I'm standing in an internal carotid artery here, and I've got my pulse Doppler gate there, when the left ventricle ejects all that blood into the ascending aorta, some of that blood rushes up the carotid system and then arrives at my internal carotid artery, and it arrives with a lot of input pressure, so it arrives a large volume very quickly. So it turns my end diastolic velocity here into a much more rapid peak systolic velocity here. If you consider the waveform below, though, you can see the way that it kind of crawls up very slowly, and what this is telling us is that we've got a significant reduction in the acceleration characteristics or the input pressure of this system here. And what this is diagnostic of every single time is there has to be a stenosis or a flow limiting lesion somewhere between where this sample was taken and the left ventricle. Now, it might be something like the aortic valve is stenotic. It might be that you have a more proximal high-grade stenosis going on with some collaterals going around it, etc. But this is a reduction in input pressure, and this means that we need to find pathology between where we are here and the left ventricle. We need to go and search for that. The second part of a waveform is from the peak of systole right through to the end of diastole. And I've given you two examples here. This is a internal carotid artery, and you can see because this vessel is feeding the circle of Willis and the brain, it is a very low resistance system. So in other words, the capillary bed inside the brain is happy to receive blood. It processes that blood and then it puts it back into a fairly open and capacious venous system with a minimum of peripheral resistance. And so we get this very slow deceleration from the peak of systole right through to the end of diastole, and even right at the end of diastole, there's still significant forward flow being demonstrated. If we contrast this to the femoral artery waveform you can see below here, you can see that the input pressure is terrific, just like the one above, but then during the early stage of diastole, it is completely different. And that's because the capillary bed in the calf of this patient is tight. And so it's not really going to receive much blood before it puts pressure back onto that artery. So it decelerates the flow very quickly. In fact, during this point in time, during the early part of diastole, there's actually more pressure in the capillary bed than there is in the feeding femoral artery. And so the flow goes backwards, back towards the heart. The reason it goes forward again slightly here is because the aorta, which has very elastic and collagen-rich walls, now contracts a little bit. That increases the pressure in the femoral artery, so it starts to flow forward again. But then very quickly after that, the capillary bed pushes back once again, and we get that flow reversal right at the end of diastole. So this is a high resistance system, and the difference really between the diastolic component of this waveform and this waveform is entirely dependent upon the capillary bed. This being an open capillary bed and this being a tight closed capillary bed. So if we walk through a couple of other peculiar waveforms, what we'll see here, this is a pre-stenosis waveform. So what's happening here is the input pressure is quite good. So what's happening is the femoral artery is getting a good bolus of blood arriving in it. But then very soon after that, during early diastole, that flow is damped all the way down, and then there's no flow through a lot of the diastolic component. And that's simply because this waveform is taken just before an occlusion, and there's no collateral there to release the blood back into the circulation. And so it's really a dead-end waveform. It's like a thump at the stump, they call it. What about this waveform? So in this waveform, the input pressure is very, very poor. So between the end of diastole and the peak of systole, you can see it's not a rapid vertical rise. In fact, it's not much more than a slight incline that you could walk up. So there's a very long time between the end of diastole and the peak of systole. And what this is telling us is that somewhere between where the pulse Doppler gate is placed for this waveform and the left ventricle, there is a significant high-grade stenosis or an occlusion. Now, what about the peripheral resistance component, the second part of the waveform, from the peak of systole to the end of diastole? Now, remember, this is a common femoral artery, so we expect this to be a high resistance waveform with a very tight capillary bed. But what we're seeing is quite the opposite. We're seeing a very, very low resistance capillary bed. The reason that we're seeing that is because during the previous cardiac cycle, of course, the capillary bed received only a fraction of the blood that it would be receiving if the patient did not have that proximal stenosis. So the capillary bed is starving. The capillary bed is waiting for blood, and it's opened itself up in the hope that more oxygen and more nutrients might arrive. So the capillary bed has changed its resistance characteristics to a very low resistance system now. So this is what we call a tardus parvus waveform. So we have a slow rise, a very long acceleration time, and this is by virtue of the low input pressure. And then we have a very low resistance diastolic component, and this is because the capillary bed is never satisfied, it's left empty, and so it's opened up and it's creating a low resistance situation. There's a couple of other interesting examples. This is an aortic stenosis, and so this is in the internal carotid artery. And as I scanned through this patient, we saw the same characteristics in the common carotid artery, in the contralateral internal carotid artery, and then in fact we could see the same characteristics in the brachial artery, in the upper arm, and in the femoral artery in the thighs. And the characteristic that we saw throughout all of these was a delayed input pressure. So we've got this long acceleration time as a product of a low input pressure, and then the diastolic component here is really as you would expect from an internal carotid artery with low resistance characteristics. But why would you have a slow acceleration time, a long acceleration time, and reduced input pressure in all the vessels all around the body? And that is because you have an aortic valve stenosis. So it's creating the same hemodynamic effect all around the body. You can see a similar thing when you have aortic regurgitation, and you get this biferous waveform, which means to strike twice. So when you feel the patient's pulse, instead of going boom, 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 it's going boom, 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 boom. So you've got this double pulse, and that's because during the ejection of the blood from the left ventricle, you race up here to peak systole, but then the aortic valve collapses and allows regurgitation back into the left ventricle, so we get this reverse flow. And then, of course, we get a bit more forward effort from that left ventricle as we get this second peak here, and then we run off down through to the end of diastole. So this biferous waveform, if you see it duplicated in multiple places around the body, can be a very good clue that the patient has aortic valve regurgitation. So what's going on here? Now, this is a common femoral artery and a profunda femoris artery. And this is a great case to explain why I don't like the terminology of triphasic, biphasic, monophasic, because I think it's a little oversimplistic. Now, in a common femoral artery and a profunda femoris artery, I would expect to see triphasic waveforms, and if the patient is a little older, maybe a biphasic waveform, but never a monophasic waveform. But here we have both of these vessels with monophasic waveforms. Now, what is this telling us? Now, if you break it down into the nomenclature that I've been discussing, you'll see that the first part of the waveform in both instances is quite a steep uprise. So there is very, very good input pressure. So I don't think we have a stenosis between where we're sampling here and the left ventricle. That looks fine. but then the peripheral resistance is reduced. Now, why can you have peripheral resistance reduction? It can be because you're getting a lack of input into the capillary bed, but because we have excellent acceleration time, excellent input pressure, this seems very, very unlikely. So what is it that's making the capillary bed be open and relaxed? Well, there is a very common pathology that we see in the lower limbs that can cause this phenomenon, and this is what it is. So if we now look at the great saphenous vein, you can see that it is absolutely hosing blood back at a great rate of knots. And then when we look in the groin, we see multiple reactive lymph nodes. And when we look at the skin in the calf of this patient, we can see it's shiny and red and cellulitic. Now, when you have cellulitis, which is a bacterial infection of the skin, all of the capillary beds in the calf open up. You get this hyperdynamic superficial venous return waveform. And what it means is once the capillary beds are opened up, they're no longer providing that high resistance pushback. So in other words, the resistance characteristics, the second part of the waveform, now represent a low resistance system rather than the expected high resistance system. And none of that monophasic waveform was generated by an arterial stenosis. It was all generated by alterations in the capillary bed, and in this case, because of the cellulitis infection. So what's going on here? Now, this is a posterior tibial artery, and I'm scanning the patient, and they're just laying down beautifully, quiet, playing with their phone while I do their scan. And I'm watching this waveform, and I'm thinking to myself, what the heck is going on here? It's monophasic now, and then it becomes sort of biphasic, and then rapidly becomes triphasic, and then it returns back to monophasic again, all just while I'm watching it. The patient's not moving, I'm not doing anything funny with my transducer, it's just the patient's physiology altering. So if you look at that monophasic waveform, my radiologist might say to me, Steve, where's the stenosis here? Because I can see you've got some monophasic waveforms in the posterior tibial artery in the calf of this patient, but I haven't seen on your worksheet where you've indicated that there's a hemodynamically significant lesion. But if you look at the monophasic component there, the input pressure is actually excellent, and it's just the peripheral resistance that has reduced. So how is this happening? What is making this possible? And it is not because it's cellulitis, because if it was because of cellulitis, it would be a constant feature. This is a resistance from the capillary bed that seems to not be able to make its mind up. One minute it says, oh, I want to be high resistance. Next minute the capillaries are sort of going, oh, no, it's okay, let's open up and let's allow this to be low resistance. So the answer to this question is that it is variations in the autonomic vasomotor tone of this patient. And what this means is that the arterial wall of the blood vessels have a muscular component, and inside that muscular component, the autonomic nervous system can regulate the compliance of the vessel wall. So in other words, it can tighten the muscle up and it can loosen the muscle off to allow more or less flow to go through the capillary beds in this calf. And you can see here that the autonomic vasomotor tone is really variable over time. So right now in the waveform, it's tightening them up, so we're going into a triphasic waveform. And then a little bit later on, like now, you can see it's really into a monophasic type pattern, and it's highly variable. So if you have a look at a vessel wall, all veins and arteries are made the same way. They have a tough tunica adventitia on the outside, and then we have the very important tunica media, and this is the pink bit in the middle, and inside this is largely made of muscular type material, and this is the component that has the neural supply to it, allowing that muscle to either tighten up and reduce the lumen or to relax and open the lumen up. And of course that will then alter the peripheral resistance characteristics of that capillary bed. And then of course on the very inside of the vessel we have the tunica intima as well, with the blood sitting in here. So here we have 4 separate waveforms taken in the femoral artery system of this patient. You can see we have variations between triphasic, monophasic, triphasic, and again monophasic. And in fact, if you watched any of these vessels over time, you could see them switching between monophasic and triphasic and then back again quite regularly. And this is literally the patient's capillary bed blushing. So it's that involuntary autonomic vasomotor tone variability where the capillary bed is opening up and allowing the blood to flow more freely through it, and then it's tightening up that muscle tone to create a higher resistance system. It's not pathological, it's just physiological. It can be a little bit annoying as a vascular sonographer because then you have to go and explain away monophasic waveforms, but if you think about waveforms in the way that I described in terms of input pressure and peripheral resistance, I think then you can make a good case for this to be an entirely normal study. So that's what makes you blush. So whether it's your cheeks or whether it's the capillary beds of your calf, it's really the same process. Happy scanning, and bye for now.